Okay, I'm being very prompt. Oh my God. Hi everybody, I'm Gail. Thank you for coming to our talk. This is Hillary and Kyle and Jeff. We are from the Climate Change and Health Interest Group and the Wilderness Medicine Interest Group, and we are going to talk about heat stroke today because it's important, and also it felt right because we're in Phoenix and it's already hot outside. And I went for a run and it was snowing a week and a half ago where I live, and so I'm like having some cognitive dissonance. So I think we'll get started. We have no disclosures, and I skipped. Sorry.
That's okay, Gail. I'll forgive you. Hi, I'm Kyle Martin. I'm from Brown University. It's a pleasure to be here talking to you today about heat, which is a big problem. No matter where you are in the country, as we'll reference, heat is becoming a bigger and bigger problem. In Arizona, it's most obvious, but across the entire United States, we're seeing trends of warming. And this is creating problems for us in the emergency department. And while today we're going to talk specifically about heat stroke, heat also has effects on the physiology of the body, leading to increases of things along the lines of heart attacks and strokes. People can have increased flares of chronic respiratory diseases like COPD and CHF as well. And that's something that we won't focus on today, but it's worth mentioning that this last year was one of the hottest years ever, particularly focusing on last summer. July 2023 was the hottest month ever recorded globally. And I guess that's needs to be taken with a grain of salt, because when did people actually start recording temperatures and keeping them in a journal or wherever they keep those sorts of temperatures? But really, if you can remember July last year, it was extremely hot. And I remember reading articles about Arizona where you would have people who were falling onto the pavement and suffering third-degree burns. So heat is becoming a bigger and bigger problem. This is just referencing what I was just talking about. So last year, Phoenix had 31 days where the temperature was greater than 110 degrees Fahrenheit. Or if you're more of a Celsius person, 43.3 degrees Celsius. We are seeing increased ED visits as a result of heat-related morbidity and mortality. We're seeing more hospitalizations and we're seeing more deaths, and these are increasing over time. But it's important to remember that this is likely an underestimation of the number of heat-related cases presenting to emergency departments. And the reason for that has a lot to do with coding. So when people are coding the final diagnoses for patients presenting to the emergency department, you might be writing dehydration, but if that dehydration is due to heat exposure, you might not necessarily be recording or coding that. So it's important to remember that we're not catching all of the heat-related cases that are coming into our emergency departments, and regardless of that, the number of heat-related illness cases is on the rise. Jeff, do you want to? Oh, well, I can speak really quickly about this. Heat-related illness tends to affect vulnerable populations. And when I talk about vulnerable populations, I'm talking about minorities. I'm talking about people from lower socioeconomic statuses. We're going to talk a little bit about redlining and how populations in redline districts are particularly vulnerable to heat-related illness, and how these areas tend to become urban heat islands. This concept of urban heat island has a lot to do with tree cover. So the rough difference between ambient temperature under shade or under full sun exposures is about 10 degrees Fahrenheit. So areas of cities that don't have adequate shade cover tend to be on average about 10 degrees hotter. And that's relative. It can be even hotter if you're in an area with a lot of concrete buildings. So in this general corridor of Phoenix, for example, where you have a lot of large buildings and not very much tree cover, then the temperature can be even higher than 10 degrees difference than that same sort of exposure in a shaded environment. So minorities people from lower socioeconomic status, the unhoused, so people who struggle with housing insecurity are at higher risk of heat-related illnesses. Poverty, people who struggle with affording things like air conditioner, for example. And then it's important to mention other groups as well, like the elderly and children. Children in particular, when you think about potentially being left in hot cars inadvertently by parents. You also think about children who are in high school who might be on certain types of medications that can predispose them to heat-related illnesses. For example, stimulant medications like Adderall can predispose children to having heat stroke and other heat-related illnesses. And then elderly populations are at higher risk as well of heat-related injuries, morbidity and mortality. That's a dual sort of risk for elderly populations, one being medications that they're taking, which can put them at higher risk of overheating. Things like anticholinergic medications, for example, can put them at higher risk. And then secondary to that is the physiology that changes as we get older. So the body has less ability to compensate for temperature changes, in particular heat, as individuals get older. So here, just referencing what I mentioned about the extremes of age and comorbid diseases like cardiovascular disease, renal disease, pulmonary disease, and mental illness. All right, I'm going to hand off to you now, Hillary.
So just a few moments on kind of the, hold on, I'm shorter. A few moments on the pathophysiology of heat stroke so that we're all on kind of the same page here. So this is a condition with a really high morbidity and mortality. And there is a continuum between heat exhaustion and heat stroke, but it is hyperthermia with some type of CNS dysfunction. And that can be altered mental status, it can be seizures, it can be coma, it can be any kind of hemodynamic instability, which has an even higher amount of morbidity and mortality associated with it. So when the body overheats to the point that it can no longer compensate for that or dissipate heat, that is where you come into heat stroke. And this can be, there's exertional heat stroke and there's non-exertional or classic heat stroke. And exertional is our marathon runners, it is our athletes that are outside in the heat, it is people who are exerting themselves out there, people who are working in outdoor environments like construction. And then non-exertional heat stroke or classic heat stroke are the populations, the elderly, everyone who's just exposed to those elevated temperatures that for whatever reason, they are either the extremes of age or are not able to compensate and to dissipate heat as well. And it could be because of their comorbidities as well. So when you think about the differential of this, it is very broad. Obviously, hyperthermia and altered mental status has a very long differential, including things like sepsis, anticholinergic overdoses, thyroid storm, different types of intoxications can be part of this as well. But because it has such a high morbidity and mortality associated with it, we have to act very quickly, and as we do with everything. So that is where we come into talking about the importance here of, again, keeping a broad differential, but also having very rapid intervention. And also thinking about what may have led that person to be exposed to that heat and not be able to compensate for it, such as intoxication, or if they're not able to dissipate things because they have burns of that type of nature, or if they just, again, have comorbidities that put them at a higher risk. So that rapid intervention is where we want to help make an intervention.
Okay, so when we think about heat injury, we want to think about both the duration of exposure and the degree of exposure. So there's a couple of ways that we can think about heat. There's the heat index, which is the one that's most often reported, and that's what you'll see usually in weather reports, and that's a combination of heat and humidity, and that is kind of like the human experience of heat. And then the wet bulb globe temperature was developed by the military and takes into account other things like shade, wind. It's a much more complex measure, and it's thought to be maybe a little bit more useful, but again, it was developed with military recruits in mind rather than the general population. So in Fresno, it's hot. When I was a resident there, we would have this morbid competition to see who could get the hottest patient in July, and there was a week during my third year of residency where every single one of my co-residents and I in my class had patients that had a core temp of 108 or higher. Joe Jacober won that competition. So in the spirit of this, some of the faculty developed this code heat stroke, and this kind of gets at the urgency of treating heat stroke. The idea that, as with a STEMI or a stroke or anything else that we do in the department that takes a full interdisciplinary team to address it quickly, like this should be on that list of things. And so we came up with this. This is our kind of like code navigator that you see on the left. It starts with an overhead page to the recess bay like everything does, and it's doc, resident, nurse, techs. We do like the whole thing. We work up the entire differential that Hillary mentioned, and then we implement some cooling measure of some sort. Usually these patients are getting intubated, and we're thinking about the quickest way to cool them. One of the things that we started using during our time implementing code heat stroke was the Arctic Sun, which is like a cooling blanket. It's a proprietary tool that added like a lot of extra training into everything. And then we would have like, some people would do the chest tube thing, some people would do like lay a sheet on top of the person that was wet and spritz them with water and put cold fans in. And then Jeff is going to talk about my personal favorite, and I think probably the most effective.
Thank you. My name is Jeff Komp. I'm one of the core faculty for our emergency medicine residency here in Phoenix, Arizona, Maricopa or COPA. I really want to talk about our strategy. For around the last 3 years, we have now done a cold water immersion only process for our heat stroke patients. We're essentially putting people in body bags filled with ice water. And to set the stage a little bit about why we're doing this, we've talked a lot about the pathophysiology and why we have to worry about this. There's a great slide that we talk about, hey, for average, there's been 702 deaths, but that's pretty old data. Just for a little bit of, grounding, here in Arizona last year, we had 645 deaths just in Arizona. That was 50% higher than the year before. And again, July was the hottest month ever recorded. A large majority of our deaths occurred in that area. So what we really did a couple of years ago was that we need to get better at this. And looking at our friends from the sports med world as well as pre-hospital and EMS, where we're treating exertional hyperthermia with dunk tanks, different kinds of ice baths. No one's really published or said, hey, we should be doing this as a protocolized management in the ED. So again, to set the stage, cold water immersion really takes advantage of a lot of physics and physiologic processes. So it's water, the interface of water to skin is around 24 times greater for heat dissipating properties than just air to skin. Because we have a huge thermal gradient, the really cold water and the hot skin, we can allow for a lot of energy transfer. And in some of our pre-hospital literature, it actually has been shown cold water immersion is about 2 times faster at decreasing core temperature than our regular spritz and evaporative cooling measures. We're in the process now of looking at our last year's outcomes and last year's data to see if in-hospital cold water management or cold water immersion has similar rates and speed of our out-of-hospital management. But what we're also finding out is we're having a very mixed picture. So it's not just exertional and it's not just our classic heat stroke, we're having components of both. So we're seeing a little bit of some different data, and we're excited to talk about that. So what are we actually doing? What we've designed, and just very similar, we have a protocolized area where we have all of our materials. We have our body bag, we have invasive temperature management, usually spot checks with rectal probes, and then a Foley for constant temperature management. We've had a lot of discussions with a lot of different departments in the hospital, and what we're able to do is have ice given to us by our cafeteria, because we were finding early on we were exhausting our regular cups of ice machines. We're zipping people in. Usually, I think there was only one patient last year that came by personal vehicle with heat stroke. So usually we get a bit of a heads up. Usually EMS will let us know. We'll lay the body bag on our trauma resuscitation bay. We'll roll the patient in, actively cool, as well as obtain vitals, obtain IVs. A couple of years ago, we published a case report where we cardioverted a patient in the cold water body bag. So we're continuing to follow ACLS, continuing to follow resuscitative procedures while we're treating and managing the hyperthermia as well. The thing that we've been finding is the time and the temperature. The time is pretty fast to get someone to a target temperature. For us, we take them out at 39 degrees because we're finding that it takes a little bit extra to get them actually out, and that continued dropping of temperature kind of gets us to that area that we've been looking for. We've also found, obviously, it's super messy. There's water everywhere. So we do a lot of training with our nursing, with our residents, with our staff about the proper procedures, body substance, or BSI, making sure that we have towels down, keeping everyone safe in these kinds of situations. And then the last one is we cut the bottom of the bag, let it drain out into a basin, and then roll them out, covering them with dry towels. We still have to do, obviously, all of our other development, management, making sure that we're working up other causes of hyperthermia and ultramental status as well.
Okay, so this is the fun part where everyone gets to talk about their experiences with heat stroke. Personally, on our end, starting with the Arctic Sun, the first patient that I put in an Arctic Sun pooped all over it, and then everyone threw up their hands in frustration and just went and grabbed a body bag and we filled it with ice and called it a day. So there's all of these kind of things that we have to think about as we're continuing to figure out how to manage this going forward. As Jeff kind of mentioned, it takes a lot of training with these new procedures, right? We have a whole new protocol that we're following. We have to get everyone on board. And then also just like, what do you have in your hospital? Like, has anyone here treated heat stroke? How did you do it?
ThermoGuard,
What is that? I don't even know.
cooling catheter.
How did it work?
So like a central line of cooling.
Okay, did it work well? Did you like
Yeah.
it? Cool.
We did evaporative cooling with fans.
Yeah.
Did everyone know where all those tools were?
After they did a QI project to make sure we
Oh, fantastic. All right.
Yeah, so that's exactly what, like, especially in places that don't see this very often, right? Like, who knows where it is? Who knows how to find the big fan? Who knows where this cooling catheter is? Like, who?
Our hospital actually, when we did the project, then mandated that you could only use a fan once. Once it had been blown on one patient, you must use a new fan, so we have a whole room of fans.
And that was actually something with our hospital too. When something is used, quote, for patient care, then it becomes an issue. And that's why, you know, obviously I'm the body bag guy, but they're fairly readily accessible. They're fairly cheap. You know, we're coming up on similar issues, as well as some people just kind of doing what they wanted. You know, it's much easier when you have a much more cohesive and collaborative management strategy with the whole department. Our attendings know what we're doing. Our residents know what we're doing. Our techs, our nurses, everyone knows that when we're having these patients come in, this is what we do. And it's really showing a really big collaborative effort in patient care.
Yeah, take some of the opinion out of it and some of the confusion out of it.
Yeah. I think a big issue that we had with implementation was I saw a couple of eyes just sort of like raised when I said we're putting people in body bags, which was kind of what we were having to do when we were talking with our hospital admin, right? So you're going to do what? So the discussion and finding some of the literature about why this works and some of the rates of cooling and where this came from was really important. I mean, we had to talk to our trauma teams. I mean, the amount of people that are found down with elevated temperature, in some places that's an automatic trauma activation, right? So what does that look like? How do you co-manage with another service line? Same with disposition. We talk to our medicine colleagues, we talk to our ICU. What will it look like after we cool them, but we're still having some of our downstream effects, some of our kidney injuries, hematologic, liver, cardiac, I mean, all of these things. What's a safe disposition? So outside of just the in-department challenges, also keeping in mind other departments and other admin structures that would be helpful in having that discussion.
Then I think the other thing to think about is, like, how many of you work somewhere that you don't think you would ever see heat stroke? Where do you work?
Detroit.
I challenge you to rethink your thoughts. So there is a study done in, I think, 2014 by NBER, which I can never remember what it stands for, but it was an economic study, and it looked at zip codes. It overlaid CMS data and NOAA data for heat, and it found that the regions that are cooler are more likely to see more ED presentations and hospitalizations for heat-related illness and associated heat, things like cardiovascular disease and respiratory disease, than the hotter climates, because there's no baseline adaptation. And so even at cooler temperatures, I'm currently doing work in Alaska, and what we're finding there is that at like 70 degrees or 75 degrees Fahrenheit, we're seeing presentations for heat illness, we're seeing presentations for cardiovascular and respiratory illness that you would never expect to see at those temperatures, but it's just because there's no baseline adaptation. And so thinking about how do you identify this, does your team know what to look for? Are you missing it? So just having it on your radar, especially as things continue to get warmer going forward, I think is going to be a really important conversation to have with your teams.
And kind of piggybacking off of what Gail said, I work in Rhode Island, and last year the Providence Marathon was a balmy 75 degrees. And when you think about 75 degrees, you think, oh gosh, that's not too terribly hot. But the average temperature for early May in Providence, Rhode Island is somewhere around 60 degrees. So with that change in temperature, we saw our hospital system overwhelmed with visits for heat-related illness and heat stroke. In fact, there was a 27-year-old from Boston who came down to run the half marathon, ended up dying of heat stroke. So I would encourage you to not think in terms of absolute numbers, but think of a relative variation. So even in an environment where you might be seeing temperatures in the 70s, you can still have exertional heat stroke and heat-related illness.
Any last thoughts? I think that's it for us. Thanks. Oh, yeah.
I had a question for the body bag protocol. I know, as you know, a lot of the nurses have been hesitant, like back in the vision of like bowel movements.
They will.
Yeah.
10 out of 10 times. A lot of it is with preparation, is with saying it's going to be a little bit messy. And what we need to do is I either take a data-driven approach of saying it's going to be a little bit messy, but let's talk about the benefit that we could be providing to our patients with this, as well as the challenges and, frankly, if I could be frank, the amount of manpower and hours it's going to take to monitor someone with a much more prolonged or inefficient cooling time that's going to have to record all the different temperatures and record everything. For us, we're rapidly able to get them into a bag. We're rapidly able to cool them and then work on more steps in our differential diagnosis. So I don't want to say adherence, adaptation and education and being intentional about it, in my opinion, is going to be the best way. To have a unified language from your department and including nursing in the development of the protocol is huge, right? So when they are able to say, hey, here are the concerns that we have, that's great. How can we approach this together? That's going to be the way to best apply this kind of a new technology.
And just a quick question on logistics. Do you leave an extremity out for IV access, and do all the patients get intubated and paralyzed, plus minus?
Actually, no. All patients are not intubated. I've actually had 2 patients anecdotally last year that woke up and told me they were too cold. We were able to reverse them that fast. And then secondly, we don't leave anything we don't leave anything exposed. So we put them with a little bit of head up, so that we have a little bit of dependency of the water. We're able to place the leads, and then we will put an IV in and then tuck the arm back under. What do we do in a sense of disposition, or how do we like co-manage?
Specifically our trauma team also wants to.
Sure, absolutely. Well, so early on, we had a lot of conversations about, frankly, with radiology, can we put our patient that's now a moving water balloon into the CT machine? They weren't super excited about it. But what we're able to do is work with trauma and frankly, make decisions and descriptions. What's more likely, right? Is it more likely that we think that this is related to the trauma because of physical exam, history, point of care ultrasound, point of care testing, and then we focus on that pathway? Or do we say, together as a team, as a treatment unit with trauma and EM, do we need to cool first and then work on getting the next stuff, or the next steps? And it's, frankly, can kind of go back and forth, and without disparaging other specialties, it's very much physician dependent on how much participation there will be, is the way that I'll say it.
I think there's another hand in the back.
I just wanted to ask a question real quick of the audience. How many of you are familiar where the cooling shelters are in your community? Raise your hand if you are. So that's one way that you can be useful as a physician in the emergency department, is to be aware of where those shelters are located and advocate for discharge instructions that contain information as to how to get patients to those shelters. I'd even encourage you to go above and beyond. Go visit the shelters, so you can see what it's like for patients who are trying to access those shelters on hot days. See what the barriers to care are so that you can conquer those barriers. Even more important than us treating heat stroke when it comes into our ED is preventing the cases of heat stroke from coming into our ED. So learn about your cooling shelters, advocate for cooling shelters in areas that are appropriate in your city. Don't make sure that they're located in areas where they're going to be of most benefit. And then, we are physicians. I think SAEM will get mad at me for saying anything political, but you can advocate on a legislative level for increased funding for cooling shelters to prevent heat-related illness in your areas.
And also working with your transportation to get people there. So in Fresno, if you're going to a cooling shelter, the bus system is free to get there. And so that provides the service to actually get people to the cooling centers. And it's great if people know where they are, but if they can't get there, what's the point?
That also brings up safe and appropriate discharge. In July and August, if I'm able to cool someone who hasn't quite gotten heat stroke, and I'm thinking I'm going to discharge them, still 115 outside. So how am I going to work with this? And one of our QI projects last year was identifying and finding all of the different heat relief shelters and adding that as part of our discharge instructions, as well as helping out with rides, because that is a huge feature.
And getting social work to help you with that. For the same reason that you wouldn't send your patient out in, -degree weather in New England, you would also want to think about, the appropriate place for them to go. And getting social work and really educating, not just, getting the whole department educated on how to recognize these cases and a protocol as to how we're going to take care of them.
Thanks, everybody.
Thanks, everybody. Obviously, we're very passionate about heat.
Yeah.